Thank you, Chairman. Thank you very much for the invitation from the VNVIS that we have a chance here to come to this beautiful city. Thanks, Dr. Chang's invitations. So today I'm going to talk something about complex aneurysm. As a hybrid neurosurgeon, I will do open also endovascular. So there is some sharing of what we are doing in our center and the usage of the relatively new intracerebral device that have been available in Hong Kong. So I have nothing to declare, but I visit this beautiful imperial city, which I like the history very much. So what makes aneurysm complex? In fact, there is a lot of features that we will think is, it's not a simple one, including wide neck, bifurcation location, particularly with the branches incorporated, large or giant, and fusiform and dissecting one. So if you're doing aneurysm treatment, of course, we always think of clipping versus embolization. These are all long-term battles between open and endovascular. We have a lot of points that we need to consider, including what we prefer for clipping and what we prefer endovascular, and the possible complications that we have to take care during the procedure. So the ISTEP, of course, had a very long influence to what we are choosing in the treatment. But long-term care, you can see here, for the clipping and for coiling comparison, seems endovascular groups get a bit more likely to get people, patients, to be alive and independent. But how about other centers study? There's of course, as a neurosurgeon, Barrows, they did a lot of open neurovascular procedures. They have three consecutive papers published about aneurysm treatments. And the latest one is 2020. And in fact, they show for posterior circulation aneurysm, seems coiling get a better outcome in the group. And clipping, of course, they have more favorable complete occlusion rate at 10 years. There's all well known to our peoples in the world. So as clipping versus coiling, of course, there's a lot of papers, and you can see most of the papers code clipping will have lower repeating rates, and of course, operation rate will be higher. But versus coiling, will have less vasospasm rate and reduced poor outcome. In this paper, of course, they will try to stratify the treatment according to the age. And you can see the top one for old age people, particularly for more than 80 years old, if you offer open surgery like clipping, usually they will carry more morbidity and mortalities. And you can see here that they stratify the effectiveness and also the safety in considering whether you will favor clipping or coiling. And this is the study they proposed for the considerations. And of course, if you consider poor outcome cases, seems most of the people, they will like coiling. How about pressure effect relief? This is a paper showing the third nerve palsy induced by aneurysm. If you do clipping or coiling, seems the pressure effect can be relieved better with clipping rather than just coiling or flow diverter with coiling. So in our center, as most of the well-established center in Asia and the world, most of the cases now will be taken care of by embolizations. And we have the ratio around 8 versus 2. We usually had around 100 to 120 cases per year in our own center. Particularly in those cases, we review those difficult cases, including large giant aneurysms, and you can see the distribution of the large to giant aneurysms, mainly over the ICA as a majority. And we have almost half of the cases that have been admitted because of rupture. So we have to take care early or urgent, depends on the situation of the patient. And you can see here the treatment options. Around 1/3, we did clipping for those patients, and 1/3 we just did simple coiling. And for another one, we had the flow diverters plus coiling. There is a simple comparison between all these measures, and you can see for the operation rate, of course, the um, clipping will have a better operation rate and with better recurrence rate. But you can see compared to simple coiling or flow diverter versus flow diverter versus coiling, flow diverter versus coiling seems to getting a better result for our cases. There's some education case that we have been doing, start from a recurrence MCA aneurysm. This have been done with the coiling in India before, but she was found to have a recurrence. So reviewing the imaging, so we decided to offer clipping instead of a redo embolization. So here is some of the intraoperative videos, and you can see this is the recurrence of the aneurysm with the previous coil, and most of the aneurysm recurrence is at the base and the neck areas. And we have the intraoperative ICG that show the patency of the branches. And after the clip, the first clip is not satisfied, so we have to take out a part of the coil and reapply the aneurysm clip again. And you can see we have to take out some more coils, and in order to achieve a nice complete operation with flow preservation of the M2s. The second case is a basilar tip. Of course, has been done more than I remember 8 years ago. It's a rupture case. It's not too suitable for the coiling at that time, so we decided to go to subtemporal transtentorial approach for the clipping. And here is the operating photos. We did it as a subtemporal approach, and we identified the aneurysm, and we put the clip on over the neck. And of course, we use ICG to guide us how we can identify the branches and the aneurysm after the clipping. But around 2 months later, we've had a scheduled follow-up angiogram, which show recurrence of the aneurysm mainly over the previous neck area. So this time, because the patient get satisfactory recovery, and it seems to be good to have a stenosis coiling. So we did the flow diverter with surpass evolve at that time with coiling, and you can see post embolization that the result looks okay. The third case is a giant aneurysm. You can see here, present with initially thought to be a pituitary tumor, but turned out, of course, it's an aneurysm with bitemporal hemianopia. For this one, we also use the surpass evolve with the coiling. And you can see here before and after the treatment, the results looks good, and the follow-up MR and also the angio seems and show no recurrence, and the patient got an improvement of the visual field more than 50%. Of course, there's some residual visual field defect, but the patient was happy. But how about wide neck aneurysm nowadays? After so many years evolutions, there is a lot of device and gadgets that we can consider for the wide neck aneurysm. And this is a paper published by a New York group showing all the, at that time, 2019, there's possible devices that will be available in the market. Mind you, on the lower bottom, the so-called novel device nowadays seems not to be novel. And as Professor this morning has been shown, the web have been widely used nowadays. So, but at that time, it was really new to our people. So for the limitation of our traditional approach to wide neck aneurysm, of course, start from simple coiling, stenosis coiling, and flow diversion. There is some consideration, and there is some limitation, of course. So there is, as the paradigm shift, the flow disruption, or the so-called intrasaccular flow distortion devices has been designed and have been applied to our cases nowadays. Of course, the key advantage is there's no peripheral vessel manipulation required, or most of the time it can preserve the branching vessels patency. And of course, the reduction of the need for antiplatelet drugs and also immediate flow distortion are the advantages. So usually it will be indicated for wide aneurysm with not good dome ratio as what we did for simple coiling. For the bifurcation aneurysms, and of course, some of the cases that have been recurrent and seems they can be considered this intrasacral device if the configuration is suitable. Of course, there's some consideration and contraindication you have to consider before we really suggest the patient to have this intrasacral device. Of course, not only the angiogram or CTA or MRI, nowadays we can employ the beauty of the AI with the virtual planning and 3D reconstructions that they will show from the start and also sizing and also measuring the tools and simulating the potential shape of the device that you can put to the patient's vessels. Nowadays, we're also using this for our cases. And since then, there's some papers collecting this kind of intrasacral device. And you can see here, this paper, now they don't call this a very novel one. It's an all in the market that have been doing for cases with probably wide aneurysms. And you can see there's some papers that try to study the occlusion rate and also the morbidity and mortality that used the intrasacral device. And particularly, you can see the occlusion rate. Most of the coded rate varies from 30 up to 60 to 70% of all the cases they reported. Not too bad, but probably with time we have to have more data, then we can see the long-term effect of the occlusion rate. In our center, we start to have this, apart from the web in Hong Kong. This is the ARTIST that we have been using. It is one of the more relatively new intrasacral device in the market. And the shape looks similar, but not the same as a web that we have been using for years. So the device, of course, is made of the braid platinum draw filter tube wire. And the beauty of this one is relatively soft, and it can conform more to some of the irregular bifurcation aneurysm if it is. So usually we'll have some of the measurements and calculations. Apart from using the virtual planning machine or the software, usually we'll see the aneurysms width and the height, and we can calculate the potential feasible size. And for this device, you can see usually there is a part of the so-called protrusion that you need to consider. It's not failure if you can see the protrusion. It's something about necessary so that the flow diversion can be done nicely towards the edge of the branches. And this is a referencing sizing table that we will use for our cases, that we will use the aneurysm width and the height, and then we'll have a suggest size of the RTs that we can consider. And of course, we use sim and size planning software to have a simulation for each cases before we really deploy the actual size of the RT's device. And as this is a relatively new device, there's not too many papers compared to web that they will review the effect and also the occlusion rate. But you can see this one of the paper from Austria. They show around 80% of the cases that will have occlusion rate in the period of around at least 3 months time follow-up. And for this paper, there's a few centers that makes up in 87 patients. And you can see the operation rate is also approaching 80 something. So how about our centers? So we have this device available since November last year. You can see we have 8 cases performed, and these are the distribution of the aneurysm. We deployed the ARTIST device. Here's a very quick summary of table showing all the cases that we did from the first case up to the last case, which was done around a month ago. And so far we have the scanning protocol on the day of completion with DSA, of course, and then we'll have the day 2 cone beam CT, and afterwards we have the 3 months cone beam CT. Since the last 5 cases haven't approached the 3 months duration, so you can only see the day 2 cone beam CT. So far, there's the scan show very nicely obliterated aneurysm with thrombus formed already within the sac, and the patient did not have any significant morbidity happen so far for the patients. So I'm going to select some of the cases as an illustration from very straightforward towards a little bit complicated cases. So start with the first case. Of course, basilar tip is one of the commonest case that we will use for intrasaccular device. And this is a basilar tip aneurysm, unruptured, of course, and we have the sizing with the CT angiogram. And we have the on-table rotational angio confirming the actual size of the aneurysm, and we import towards the planning station, and we measure the width and the height of the aneurysm. So initially, it was thought to be the size of ARTIST 7.5 times 4 will be the preferred size. And this is the simulation that we use. Usually, we will use the simulation one size recommend and one size bigger and one size smaller to have a comparison of the apposition and the compression effect if we are going to use this. And looks like the 7.5 times 4 or 7 times 4 might fit. So we start with 7.5 times 4 because we usually want to have a little bit bigger one to have a more better appositions. So 7.5 times 4, you can see it looks quite okay, but mind you, there's a little bit more protrusion that we expected to the parent tip of the basilar bifurcation. So we decide to change to 7 times 4, and you can see the right-hand side after the deployment, the protrusion is still here, but it looks better and nice. So we keep this as the final one. So another case, it was a case that had a rupture of the right MCA bifurcation aneurysm with clipping done around 6 years ago, and then follow-up imaging showed recurrence. And we have the sizing of the aneurysm before the ARTIST deployment. And this is the recommended size with reference to the width and the height of the aneurysm we measure. And this is the ARTIST simulation. And you can see the 8 times 4 looks the best among the bigger one and the smaller one. So this is the deployment. And for this case, because the M2 is a little bit protruding towards the neck of the aneurysm, so after discussing with our interventional radiologist, we prefer to take a SL10 along the M2 in case there's something happen, we still can have a stent over the M2. And this is the post-deployment showing you can see the aneurysm clip before and also the aneurysm with the ARTIST device. So the next case is a rupture case. So far, among the 8 cases, we did 1 rupture case during that period of time. So this is a gentleman with clipping, with coiling of the previous rupture aneurysm at the ACOM at the same site. Around 9 years ago, he's defaulted our follow-up and then come back because of another bread afterwards. we find there's a sizable recurrence of the aneurysm over the previous embolized site. So we measure the size, and you can see this is the recommended size of the RTs. And so we go ahead. And for the simulation, images looks like this. So for a rupture case, as there is a pseudoaneurysm sac, you can see on the top of the aneurysm. So we first deploy the coil to the pseudoaneurysm sac, followed by RT's device. And this concept we got this and recommended by some of the professors from Australia. It's called the cupcake technique. That means you put the coil on the top of the aneurysm, particularly for the pseudoaneurysm, and then followed by the intrasaccular device to make it as like a cupcake that we have in our own days. And it looks quite okay in the deployment. And the last case I'm going to show is a ICA aneurysm at the segment of the PCOM. So you can see there's quite a large PCOM artery associated with the neck of the aneurysm. For this case, we measure as usual and also do the segment sizing simulations. But for this case, with the color worry, something might happen, particularly during the deployment. And so we put the potential septicity along the MCA M2 so that we can use the septicity to do some protection and molding during the deployment of the RT's device. We have the two-hand techniques. I myself doing the deployment, and my partner radiologist doing the septicity part. So this is final angiogram shown. So in conclusion, I would say, although embolization of coils seems to be more favorable, but still we have to consider clips in some of the cases. And of course, intrasaccular device, as we've shown, seems to be one of the new directions to address the previous limitations of the traditional approach. But of course, we have to have the team together to make a decision and to do the surgery together. So thank you very much. This is Hong Kong. This is my hospital. And this is the angio suite. We are doing the cases. And coming, our hospital is going to move to a new one at the old Kai Tak Airport area. So if people that have been visited to Hong Kong at that old airport nowadays, in next year, you will come back with the hospital now. Thank you very much.
Thank you.